Hello, I'm Dr. Bolanle, your host on the Bright Minds MD and your mental health podcast. Here, we discuss topics designed to explore the full spectrum of mental well-being. You'll hear from experts and listen to personal experiences that inspire and inform. So, whether you're seeking insights, solutions, or just a dose of motivation, this podcast is your perfect companion. Hit that subscribe button and join us on this incredible journey to mental well-being. Your whole health starts with your whole mind. Let's get started. All right. Welcome. Good morning, good afternoon, good evening, whatever time you're listening. This is Dr. Bolanle Atkin-Rambi, psychiatrist and founder at Bright Minds MD, serving New Jersey and New York, where we help people with depression, anxiety, ADHD, and other psychiatric disorders to feel better using fewer medications and wellness practices. I have someone here today, Dr. Kara Pepper, who will be discussing about eating disorders. I'm going to let Dr. Pepper tell us a bit about herself and introduce herself to the audience. Welcome, Dr. Pepper.
Hi, thanks for having me today. I'm Kara Pepper. I'm a primary care internist, which means I take care of adults over the age of 18 in the outpatient setting. I was a ballet dancer before I became a physician and brought all my perfectionism and workaholism with me and found my way into a career mostly taking care of folks with eating disorder behavior, but more importantly, people who just want to find a safe place to receive care and not be told that the only solution to their health problems is to lose weight. And so that's how I founded the practice that I've been in for now 2 years.
Awesome. Thank you. And so you talked about weight right there, and that piqued my interest. Who are these people who are being told to lose weight to lose their problems, and what problems are they trying to solve?
Yeah, so we all, and when I say we, I mean collectively in America, have been told that there is a big problem with weight and how it pertains to your health. And yes, we know that weight correlates with a lot of diseases like diabetes and high blood pressure and heart disease, but there's not a single disease that folks in larger bodies get that people in smaller bodies cannot get. And so very often, because of time crunch, because of bias, because of lack of information, very often when people come into the doctor to say, hey, I've got this problem, I've got pain in my knees, or I'm struggling with high blood pressure, or I want to be healthy, very commonly the recommendation that they get is that they need to lose weight in order to be healthy. And that is not always true. In fact, most of the time it is not necessarily true. And so what that means from my standpoint is you get to decide, every person gets to decide what health looks like for them. And for some people, that means addressing metabolic issues. But for a lot of folks, one of the reasons that they develop eating disorders is because doctors tell them they need to lose weight. And so we as physicians need to be very thoughtful about the recommendations that we're getting. So that's just a little bit about how that weight issue shows up in our practices.
Awesome. Thank you. And so I really like that you're highlighting the fact that each person gets to decide what health looks like for them. And I imagine then that your role will be to guide them in that process to accomplish those goals.
Yeah. Like a very easy example, if I had someone come in and say, hey, I just want to be healthy. And I say, what does that mean to you? And they say, well, I just want to be able to be there for my grandkids, to play with them, to get on and off the carpet and have no pain in my knees. Then I'll say, well, is that really a weight issue, or are we talking about pain control? Are we talking about mobility? Are we talking about being present with your family? Like that really informs what health for that individual means, not the kind of one size fits all. You need to change the shape of your body in order to achieve that.
Wow, that is really wholesome and holistic. And even though I agree completely with everything you're saying, I don't think I've it from that perspective. So thank you for sharing with me today a new way to think about it and also to approach that conversation with patients. Right. Now, just looking at it from the perspective of why they want to do what they want to do, because ultimately some patients will come and they'll say, I do want to lose weight. Maybe they've not heard that from a doctor, but maybe they have this idea about how they should look, what the numbers should say on a scale, or how their clothes should fit. So ultimately some people do come with that kind of concern, or bring that as a concern or a goal for them.
Yeah.
When those people come and it does become that we need to look at either how they eat or what their scale looks like, at what point do we then start to say, well, this is a disordered way of looking at food or approaching food and body size versus not? And I understand this is a broad question, so if you want to redirect it better, that would be totally okay too.
Yeah. So if I'm hearing you, okay, how do I draw the line between someone who's saying, I want to change the way that I diet, as opposed to someone who is developing a dysfunctional eating disorder, a dysfunctional relationship with food, body, or exercise? Yeah. So, I mean, I think, as you know, we have to actually talk to our patients. And so asking the question, well, why does that matter to you? If you lose weight, what do you think will be different for you? How do you think you're going to feel if you are in a different size or shape body? And is that true? Like, is it true that you will simply be happier if you're in a different size body? And like, where did that belief come from? And often people will say, well, like, I just want to be healthy. Don't I need to be thinner in order to be healthy? And again, it depends on what your definition of health is. And so the way that I start to tease that apart is really just asking the question, like, how much time during the day do you spend thinking about food, body, and exercise? And very commonly people will be like, well, literally like 80 to 90% of my day, that's all I'm thinking about. I'm ruminating about it. I'm always thinking about my next meal. I'm hungry. I'm having a lot of shame. Those are really big clues. There are formal ways to screen for eating disorders, but I think very easy questions like, tell me about your relationship with food. Tell me about your relationship with your body. Tell me about your relationship with exercise. That gives us a lot of information. And you don't have to dig much deeper than that very often. There's ways to fine tune that. Yeah.
Interesting. And as I'm listening to you, I'm thinking, when you ask a question like that or along those lines, you will find the answer will point you in all along the spectrum, but on both ends, whether it be someone who's considered very underweight or maybe restricting and on the underweight end of the body spectrum, but also in the overweight, obese end of the spectrum, the preoccupation with food, you will find, when I'm thinking of patients or people that I've encountered, and I haven't asked it specifically in that way, but eliciting how much time is spent thinking about food it will show up on both ends of the spectrum. And I thought it was important to point that out, because I think there might be a general assumption that you only find that on the end of the spectrum of people who are considered above a certain BMI, but also on the low end of the BMI there is that incredible preoccupation with eating and food and relationship with the body as well. So that's a pretty solid question, solid tool in the armament there. Thank you for sharing that. So when we uncover that, or when you talk about that and the conversation begins, which is a beginning process of the diagnosis, where do you go from there?
Well, it really, so I'll ask those broad questions, and then there's ways to start to tease some of that out. A very basic question is, tell me what you ate yesterday. Give me a sense about how you're fueling your body. And very often what the reply is, well, yesterday was different. It's not typically like that, but it's usually always like that is the answer, right? There's a lot of shame, secrecy that fuels eating disorder behavior. If you're overeating or undereating or overexercising, very often we try to keep those things secret. And so, or on the flip side, it is rewarded if you see all these influencers who are exercising hours a day and eating clean and have very kind of rigid rules around, orthorexic behaviors, we call it, this very rigid behavior. Like, sometimes they get lauded for that, but on either end of the spectrum, I'll say, like, tell me what you ate yesterday. Tell me what you're doing to move your body. How is that helping you? How is that harming you? And then asking very specific questions. Are you purging after you eat or in anticipation of meals? Are you using laxative diuretics or weight loss tools? Are you doing a lot of body checking? How often are you weighing yourself? And really kind of navigating that down can help us give a sense about what the patterns they have between food, body, and exercise. And that gives us a sense. And you mentioned earlier, it's a spectrum, right? There are people who can diet and they never develop an eating disorder. They just change the way they eat and they keep it moving. But we know that there's there's not an insignificant number of people who, because they become more and more rigid and because they become more malnourished, their brains start to become very fixated on food, and that kind of sets the train off down the tracks with eating disorder behavior. So it's a spectrum.
Absolutely. Thank you for that. And just related to that a little bit, but flipping it a little more, if someone's listening and wondering about that, or wondering about their child or their relative or even themselves, what are some things that a person might notice about themselves or that they're doing that should get them concerned to see if they needed to talk to someone about, an eating disorder being a factor in their current life?
Yeah, so we often think stereotypically that people with eating disorders have either very small bodies because they're undereating or very large bodies because they're overeating. But we know that only 5% of people with eating disorder behavior are in very undersized bodies. And that's a loaded statement in and of itself. But 95% of people have across the body spectrum in size. So you cannot wait for just weight loss to be the primary indicator. But we know if someone's losing weight, then that's something that may pique our interest. There's behaviors around food, either skipping meals or pushing food around on plates, like not actually eating the food that's in front of them. More and more rigid behavior, like I can't go out to eat with you because the food at that restaurant is not clean, or I don't like what they're serving there. More rules around food, sensory issues around food. I don't like the way it feels in my mouth. I don't like touching it. I don't like smelling it. Or if someone's eating and then they get up from the table immediately after and then going directly to the bathroom, we often wonder, are they purging? Is there something else that's going on there? And so I don't advise that people comment about other people's body size, but to say, I'm worried about you. I see that your behaviors around food are different. How's that going? Would you like to speak to someone about that? Because very often when that behavior is named, the shame monster will get really flared and they'll be like, no, there's no problem. I'm fine. But finding a healthcare professional, either a therapist, a dietitian, or an eating disorder physician like me, who really understands this to help them navigate through that. Because very often the person who's engaging in the behaviors is not really ready to change until there's a rock bottom that gets their attention.
Okay, that is so true. That's so true. Things are good until they're not. I'm thinking also another thing that I've heard, from patients sometimes also is just even talking about food. For some people, brings shame, skirling, hiding to eat, not wanting to get caught because of how either they fear other people might treat them, or they believe they may be treated about how they're eating. Like, I've heard some feedback on that as well, as far as like, hiding behaviors around food. And
that's right.
Not wanting to be seen in the way they eat. Yeah. Okay. You said something earlier though about, you said undersized, and that's loaded, and how our bodies are measured. Can you shed a bit more light about that? Your views and thoughts about how our bodies currently measured, and maybe how we could be doing it differently or better?
Yeah. So the BMI, which is the standard tool that we use to measure size, is a bell curve. It is fraught with problems and how it was originated. It technically was designed in the 1830s by a Belgian astronomer who was looking at Northern European white men who are laborers in the field and said, this is the bell curve of what those men should look like. So, you and I are women on this call. So, already it's not even applying to us here, but to the global population, but particularly who we see in America. I mean, unless you're a man in the 1830s, this was not designed for you. It's fraught with all kinds of bias, particularly as it pertains to people of marginalized identities. And so it's not a great tool. Really, the question that it was trying to answer, and there's many, many people who've spoken about this, advocates in the fat liberation space, particularly women of color, who you should absolutely listen to, and not me. They will say very candidly that this is rooted in anti-Black rhetoric. So it's a very hot topic. But for the practical application of us here, trying to figure out, am I healthy or not? It doesn't answer that question, number one. And number two, it's not an accurate measurement of adiposity, meaning how much fat is packed in around our organs. And that is the thing that actually creates the metabolic health problems that we're seeing. So you can be in a large body, but have very little visceral fat, and you're not having problems with diabetes, cholesterol, heart disease, and hypertension. And so the BMI does not measure that. So when I say undersized, it's undersized compared to what? Men from the 1830s. So it's not a great measurement, but it's the rhetoric that has been, and the language and the metric that's been used since the 1980s here in America.
For a long time. Thank you for sharing about that, and how I've heard this, and patients will say this a lot, about the BMI, and they'll say, I eat very well, I eat my veggies, I don't overeat, and I'm
That's right.
just big. But, my doctor keeps telling me to lose weight, and I don't know what to do. And this causes so much distress. So thank you for
That's right.
highlighting
That's right.
how, the fact that the BMI measurement has some problems. So
Yes.
moving away from that, right, highlighting the fact that the visceral fat is really the important thing to look at. How should we be measuring ourselves? Should we be getting tape rules instead? I don't know. I'm having thoughts in my head, and
Yeah, I think you're onto something. We don't have a great measurement tool for that, not one that's easily accessible. The best tool really is a CT scan that measures the amount of fat around the organs, which, we can't go to the gas station and get one of those quite yet. But there are ways that is being measured through coronary calcium scores. They'll measure the visceral fat. People will use waist circumference as a surrogate for that. But again, you can be in a large body, but that doesn't necessarily tell you about what's going internally around our organs. So the short answer is we don't have a great one, which is why very often you'll just hear people give the blanket statement, if you shrink the size of your body, it will probably fix your health. But that's not true for everyone.
That is so true. That is so true. Thank you for highlighting that. Very important to hear, and hopefully that's reassuring for people listening, because it's something that comes up a lot for a lot of people, and that we often talk about, but may not always know how to talk very well about. So thank you for highlighting that the BMI shouldn't send people into a spiral. As I'm thinking about some of the people, a person I care for currently who's like really, really worried about that number, and
the better numbers are the labs, which is like, how are your sugars doing? How is your cholesterol? How is your blood pressure? Is it high or not? Those are much better metrics for the metabolic health. And then there's more sophisticated ways that your doctor can walk through. But you can actually scan people now and see if there's plaque in their heart arteries, for example, to tell if there's underlying heart disease.
Should people be going around and asking their doctors for this? I imagine the answer is no, but I want it to be ridiculous for a second.
No, I mean, the test is validated for people over the age of 45. So it's something that I recommend in my practice. For everyone, but particularly if you have high-risk features, like a parent who's had a heart attack at a young age, if you're a smoker, if you have high cholesterol, diabetes, or high blood pressure. And so you can get scanned. It's literally a CT scan of your chest without contrast, and they will look specifically at the heart arteries and tell you if there's plaque that's forming, which is really exciting because it's a way to anticipate danger that may be coming down the pipelines before it's actually a problem.
And so this is for people who are 40 and over, I think you said at the beginning.
Yeah, 45, yeah. And it's not covered by insurance, but here in the Atlanta market, it's a $100 test. So it's cheaper than any other CT scan that we order. So not free, but not terrible either.
Okay. The more accessible it is, the better more people can
Absolutely.
access it without insurance kind of putting themselves in between that. You know how that
That's
works.
Right.
All right. So speaking of, I want to bring us into some practical aspects again of treatment. So you are in internal medicine, and this is your primary focus. You work with these individuals. I encounter individuals with eating disorders, so to speak, under that umbrella also as a psychiatrist, and I often have to collaborate with an internist as far as ordering labs and monitoring health. Especially if a person is actively, having behaviors that are potentially dangerous, or that could lead to more immediately or acutely dangerous events. So we do that. Who else do we include in the team of experts to help such an individual?
Yeah, I love that you call it a team, because medicine is a team sport, particularly this field of medicine. And so the primary people on these teams are the dietitian and the therapist. And there's a whole subset of those fields that is specially designated for eating disorder care. So people who truly understand the mind piece that creates the behaviors, which then creates the medical problems that end up in my domain. And so those are the two folks that spearhead the team. And then I'm supporting medically. Is this patient sick enough to be in a hospital, or do they need a higher level of care, or can we manage them in the outpatient setting? And then either I or the psychiatrist will manage medications for patients to help with anxiety, depression, OCD, or other mental health disorders that are in the background. It's really important to know that at least half of folks with eating disorders also have co-occurring conditions like alcohol or substance use disorder. And so we very often see those things overlapping. So So it's a team sport, which is super fun.
Yes, teamwork, lab monitoring, therapists, nutritionists, dietitians, all of us working together to get the person safely towards your goal, but healthy.
That's right.
I also thought that we've used the blanket label eating disorders. I thought it might be useful, I don't know if you think so, but useful to also highlight the common diagnoses, or which people may be more familiar with in their travels or encounters, that fall under the eating disorders basket.
Yes, absolutely. When I think of them, I think of two domains. Are people not fueling their body enough, or are they eating more than their body needs to meet their daily needs? And are there compensatory behaviors to get rid of food because of guilt or a desire for thinness? So anorexia nervosa is probably the most recognized one, which is generally associated with weight loss, but not always. And it's a real fear of weight gain, and it's a restrictive eating pattern. So people are not eating enough, and you can live in a large body and still have anorexia, which is an important take home. So you don't have to wait for people to be tiny. And then the next one is bulimia, which is also a fear of weight gain, but it's met by purging behaviors. And we often think of people throwing up as purging, but it can be over-exercising in anticipation or in reaction to food. It can be using things like diet pills or laxatives or diuretics to get rid of food in other ways. So bulimia is a purging disorder. There is ARFID, which is one that's not so well known, avoidant restrictive food intake disorder, which there's some of it is fear-based, some of it is an apathy, like I just don't feel like eating food, food disgusts me. Or for some folks, particularly neurodiverse folks, it's a sensory issue. I don't like the way it feels in my mouth, I don't like touching it, I don't like smelling it. And so very often those people get confused with anorexia because they're just not eating, but it's not out of a desire for thinness. It's more of a behavioral sensory issue. And then there's a bucket. And then I forgot binge eating disorder, which is exactly what it sounds like. People are overeating, binging. There's sometimes purging associated with that because of discomfort. And then outside of that, there's it sounds like one of those things, but it's not exactly those things. So you don't have to meet all the criteria. There's kind of a eating disorders not otherwise specified. They now call it OSFED, which is kind of for the things that are close enough but not quite meeting those technical disorders. So that would be the short overview.
Thank you for touching on those. And I have to say that I have a love-hate relationship with labels. On one hand, having labels and baskets help us to, have a common language to describe certain things. But in my practice, I also find that when you throw a label on something, it either frightens people away sometimes, or it makes people resistant to seeking help because they're, when you say someone's anorexic, they're like, oh, I have this BMI, or I look a certain way. There's no way I'm anorexic. But describing it in the way that you have, which is thinking of a person as undernourishing themselves overall, right? The ultimate outcome, which is what harms the body and the psyche in general, is a very helpful way to think about it. And I think that it makes it accessible in a way where people can easily understand what it means and think about themselves and identify the problem, rather than a big, scary label. And as a psychiatrist, I deal with labels a lot that frighten people, so I tend to shy away from placing a label, because the moment I give a person a label, they close up and like, no, that's not me. And it's like, okay, fine, let's not use labels, let's just think about the behavior or what's happening. If it resonates, it resonates, and then we can just look for a solution and we can put the labels behind. So oftentimes I lead with a label. I realize we didn't talk about the labels at the end, but I throw it in there, but it's a love-hate relationship. It gives us common language, but also we want to talk about the actual thing, or the behavior, or the internal state of mind, which everyone can relate to outside of the label. So thank you for breaking them down for us in that way.
Sure.
All right. Those, I think, are most of the questions I have. And looking at the time, I wonder, are there any other things you feel important that we haven't shared today that other people should know?
Yes, I think if you are listening and you're secretly thinking to yourself, maybe this sounds like me, but I just want to turn off this podcast because this feels too personal, I just want you to just acknowledge, like, maybe there's something there and you may not be ready to address it today, but your life is so much bigger than the size of your body. It is the least interesting thing about you. Like, life is really meant to be lived, and the freedom that you can get on the other side of letting this go is absolutely life-changing, because you deserve to have a life that's meaningful, not one that's centered around food, body, and exercise. And then there are plenty of resources online. Literally a quick Google search of "I need help" or "eating disorder help" will point you towards a number of databases and references that can help point you towards local resources in your area. So finding the first step, if you think that you may have an eating disorder or you have a family member that you're worried about, is just reaching out to their primary care physician or finding a dietitian or therapist in your area, and we can plug you into the system from there.
Thank you very much. Thank you. Wise words and very important. And if someone were listening today and wanted to reach out to you for help, how will they find you?
Yeah, I'm licensed in now 18 states, mostly on the East Coast, but not exclusively. And if you can remember my name, you can find me. You can see it on the screen here. It's Kara Pepper. So my website is karapeppermd, like medical doctor.com. You can find me on social media, Kara Pepper MD, and that is the easiest way to find me.
Awesome. Thank you. And we'll tag that as well in the notes, so that if someone had to reach out to you for a consultation, they'd know how to reach you. And you mentioned you're licensed in 18 states, so that makes me think that you work via telehealth, because you cannot be in 18 places at once.
I cannot. No, I've tried. That doesn't work well. Yeah. So I have a telemedicine practice, and then I'm located here in Atlanta, Georgia. So if someone wanted to be seen in person, certainly people in the metro Atlanta area, I see them in person, but also do consultations across state lines in the states where I'm licensed.
Awesome. Thank you very much, Dr. Pepper. Are you licensed in Jersey, by the way? Is this one of your states? Okay.
Yes.
All right. Good to know. I didn't even know that. I'm glad we brought that up. Okay. Thank you very much for sharing with us about eating disorders, your thoughts, and how to look at the body and the individual and our goals in a wholesome way to address that, rather than getting stuck on BMIs and numbers and those things. So thank you very much. I've learned a lot, and I'm sure everyone listening has learned a thing or two. Quick disclaimer, everything and anything you've heard today has been mostly for education. It's not medical advice. If you have any questions, certainly you can request a consultation with Dr. Pepper, as she's mentioned, or your own doctor. Again, it's all for education and entertainment only. And that said, that will be all for today. I am Dr. Bolanle Akinrambi, psychiatrist and founder at Bright Minds MD, serving New Jersey and New York, also via telehealth, for individuals who have depression, anxiety, eating disorders, ADHD, and so on and so forth, who want to feel better and live better using, again, fewer medications and a wholesome approach. Thanks again for listening, and have a wonderful day. Thank you.
Thank you for listening. Don't forget to share this with a friend or two. Until next time, it's Dr. Bolanle on the Bright Minds MD and Your Mental Health podcast. Ciao.